All right, so let's get started. We're here doing a podcast series. We're calling this Ready, Set, Gemini. And what we're doing is trying to share best practices and perspectives with our clients regarding how to navigate going forward after this virus and potentially new disasters that hit California or this nation, secondary virus or a secondary round of COVID, which we're all not looking forward to. So I have here in the studio, I have Rich Jacobs. He is the CFO and also QME and partner for NMCI, which is Rich, how would you describe?
Multidisciplinary medical clinics.
Man, that was great. Also, we have Kat Angelis, who's the general manager of NMCI on the line here. Kat, welcome.
Hi, thank you.
So, yeah, I'm really excited to talk to you guys. And just a little bit about NMCI. I'm curious, how many doctors do you guys have?
9 physicians.
Great.
Mainly PM&R.
PM&R, what does that mean exactly?
Physical medicine and rehabilitation.
Gotcha.
That's the majority.
Okay. And there's also, I noticed on your website, you guys have psychiatric and neurological specialties as well.
Yeah, we have psychologists, psychiatrists, orthopedic surgeons, acupuncture, chiropractic, physical therapy.
Wow. So multidiscipline.
Patients need a lot of care.
Yeah. Is there anything that you guys have on the horizon to add, or are you guys complete with your lineup of resources?
Well, we're always trying to foster the passions of our providers. So if certain providers have a skill set that they want to spend time using and we don't have that particular service, we try to add it for them so that they feel professionally satisfied.
Gotcha. And how long have you been in the industry, Rich?
Since 97.
Wow, so that's 20 plus years.
At least 10.
At least 10.
I can't do that math.
And Kat, how long have you been in the industry and with Dr. J, as you said earlier?
For about 18 years.
18 years, incredible. And so we'll start with you, Kat. I'm curious, what's your so since the COVID, we've started to the WCAB has allowed for telemedicine to be authorized within workers' compensation. So you've been at the forefront. You've been the person that's been quarterbacking that change at NMCI. Can you tell us a little bit about how that's gone?
Yeah, I've been really pleasantly surprised with the ways that the DWC has been adapting to the current situation, allowing medical offices such as ours and medical providers to treat our patients who are perhaps high-risk patients or just simply want to isolate at home and avoid going to public places, including their medical doctor's office. So they've really helped medical facilities and medical providers to continue to provide care. However, not all of the care can be provided. There's a lot of procedural types of treatment, injections that the patients may need that they're not able to attend, but those can be scheduled at a later time. What I really appreciate is that it allows the patient to continue their care without that interruption. So it's definitely making it a lot easier for medical providers. In terms of the authorization, I do feel that it's that they have also improved in their flexibility. And in speaking with several adjusters over the phone, I mean, many of them are in a similar situation as everyone else. They're working from home, their staff is reduced. They're trying to also keep their head above water in this situation. So I have phone calls every day from adjusters, and my personal experience is that they have become very understanding and they're willing to authorize even more so than in the past. So it's really worked out well for our organization.
That's great. That's obviously we're all in the business of keeping injured workers healthy and trying to get them back to work. What practical changes did the DWC put in place for you to help injured workers?
Well, it's a lot easier to get authorization now. The there are some things that are put in place formally, and there are other things that I'm seeing that is just the adjusters and the insurance companies that are just willing to be more flexible and also accept things that they weren't, perhaps willing to accept in the past. So, for example, if a patient needed something urgent, call the adjuster. And in the past, they were leaning more towards the side of, send me an RFA. It has to go through all the channels. And now they realize the urgency and the lack of resources to perhaps go through the traditional routes that we have in the past that was required. And, many times we're able to get authorization over the phone, get, everything squared away. So that's been a nice change. But in terms of more formal changes, we've seen that they have allowed our billing department, they allow greater flexibility. The pay is better. The reimbursement for the services is much more reasonable. Whereas in the past, I think it was so low that many facilities couldn't sustain or even offer or even consider telemedicine. So it's really nice to see that they are making both changes, both formal changes, in writing, and then also being flexible when it comes to speaking with them and trying to get quality care arranged for the patient.
Thank you. That's great. So the benefit, we all are in this industry and see injured workers that get drugged through the system, and maybe the time that it takes to get care, and the quality is probably a different topic, but the time it takes to get care can obviously be a significant problem. And I see this as maybe going forward, telemedicine being especially since it's been successful so far, as you're telling us, being a lot more utilized. Kudos to the state for getting this through, and obviously it's a unique situation. So tell us, though, I'm curious what the how you view the top benefits and compromises here. We're talking about some of the benefits. The health of the injured worker, of course, is the top benefit. But any other benefits and or negative compromises that we're going to have to make as a result of this?
Well, some of the benefits I mentioned about, the patients being able to receive care without any interruption, but also the compromises would probably be that I'm seeing here is that the patients are not every patient is appropriate for telemedicine. Perhaps 1 or 2 visits, but at some point, some patients do have conditions that require procedures. And that is where that's where we see the limitation of the benefits of telemedicine, is that those patients at some point do have to come into the clinic. And if they don't, then the provider usually has to modify their usual treatment plan. If the patient is uncomfortable or unavailable to come in, they have to respect their desire to remain sheltered in place. So, it really is something that our providers are working towards. And I think that providers everywhere are starting to kind of, adapt to that limitation. But I really like that. What I'm seeing is that the DWC is opening up the doors for several services like psych, CBT. And I think I saw somewhere about PT. I'm a little unsure about how that's working out. Mm-hmm. But I saw that there was some advances in that a little bit. But I do see that the doors are opening up for alternative treatments to be done through telemedicine, I think, in creative ways. Mm-hmm. But yeah, it's definitely not for everyone, and it does limit the providers. And some providers are comfortable with that, and others are not. So, it does kind of push us and encourage us to refine what we know and to be creative and view other channels of treatment that perhaps we wouldn't have considered in the past without telemedicine.
Thank you for that insight. And Rich, I heard it said by a doctor that physical examination is always better. And how do you balance that? How do you balance the quality of care and getting the benefits of telemedicine, especially in workers' compensation?
Well, it's a balance that isn't exactly balanced. On the one hand, patients really do need contact with their physicians, whether they're medical doctors, chiropractic, acupuncture. They need contact, and the doctors became doctors essentially to help people and to deliver care one-on-one. Telemedicine is a brand new phenomena, generally countrywide, and in workers' comp, I think it was only adopted due to this pandemic. So the sacrifices that a doctor's making on the diagnostic side, where you can't perform a pinwheel or test for radicular symptoms, you can't test reflexes, strength, you can't get the face-to-face, in-person, empathetic view of a patient. Those are sacrificed for the patient having the ability to interact with a physician and the ability to tell the physician how they're feeling and to make decisions based upon history and prior examinations and prior contact with the patient. So telemedicine is certainly better than no medicine. There's just a lack of diagnostics, but for follow-ups, if you've already established a pattern of symptoms, you may be able to manage a case way better than if the patient didn't come in for 3 to 5 months because of this.
Great, yeah, and in comp, we're in workers' compensation, and I anticipate that there will be legal objections to telemedicine. But maybe I'm wrong. How do you view the attorney side of this, or the rebuttal side of telemedicine?
I can't speak for the attorneys. What I can say is that there's right now a large debate going on for the QME side of workers' compensation and fee schedules and the admissibility of those exams and reports. It all hasn't been decided upon. There's actually webinars and all kinds of stuff almost every other day for the last few weeks in regards to how to properly conduct this, because a QME really does, on certain aspects, move a case forward. And without having access to a QME that's willing to see a patient in person, or the patient is not willing to come in. I've had in the last few months a couple of patients that just didn't want to leave their house. I've chosen to perform exams in person. That's a personal choice.
Sure.
Other QMEs, I've seen letters that just say, "Look, I'm unavailable until whenever. I know I was scheduled to see your patient, but I'm out until July." As a starting point. So the QME system is definitely going to be bogged down if they don't pass some legislation to allow, for at least the QME to establish maybe the medical legal causation. To establish, is this an admissible claim, and sort out AOE, COE issues. I don't think it would be proper to issue a final, permanent, and stationary MMI version of a QME, given that you can't do a real exam. So if someone's trying to accomplish that, I could see the defense, if they didn't like the opinion of the QME, certainly raising objection that they couldn't have come to the conclusions which were reached in a video examination of a patient, even though the MRI or EMG data supports it. So that might happen, but in terms of just getting the first QME visit to establish causation, and acceptance of a claim to move the patient down the line and have the patient begin to get the appropriate care, that's an important step.
Yeah. Sounds like things are changing. I'm curious how interpreting has been. If there's any instances that you know of that where interpreters have had to be involved in the examination, and has that been going? I'm sure it's just working out the kinks and.
Similar challenges. I could tell you that I had to send one home because they had a fever. So I had no interpreter for one of the exams. So, you're adding a layer of challenges. One of the things that we've done with telemedicine for the providers that, or the patients that don't want to be seen face to face with the provider, but would like to be in the clinic, is we've set up computers where we could do the telemedicine in our facility, where the patient is, going to an office visit where, I believe it's written in the ACOM guidelines that just the act of going to a doctor's appointment actually increases the healing process. Whereas the act of sitting on your couch and flipping on a computer to see your doctor may have less of a beneficial therapeutic effect. So,
yeah, I am sensing that this may, though, become more comfortable. It's a technological speed bump that I believe that patients having that as a barrier as they're getting more comfortable. And I think that this COVID situation, virus that's affected so many people, I think it's made people a little bit more comfortable using technology. And in medicine, I mean, that's the debate that we're talking about. And does the patient feel that they are going to have the quality of care, the same quality of care as a result of working with a doctor and being treated through telemedicine?
You'll probably have the whole spectrum.
Yeah.
You'll have some people that really want to shake hands with their doctor, and other people will be very happy to not leave their apartment, or some people don't have computer skills and or the equipment to have a telemedicine visit effectively. So there's challenges on all sides. The important thing is that everyone attempts to adapt to do what the doctors trained to do, which is provide treatment to people. And, hopefully the workers' compensation system, which has made in a rapid form some adjustments to how they allow doctor-patient interactions.
Yeah, a question that I was curious about is how this might change with Maximus and IMR. There's been huge complaints on the applicant side about IMR doctors, Maximus doctors not seeing or touching a patient at all, but making medical determinations. I could see this, we don't need to speculate on the future, but I'm curious how Maximus or how the state might be forcing Maximus to be doing telemedicine and actually seeing the injured worker.
I can't speak for the state, I can't speak for Maximus, but I could see in a quick sense that would greatly increase the costs of Maximus performing what they're doing. Maximus is the IMR leg, and they generally do a file review. And based upon the records and or statements by the providers, they make decisions, and that's the way that was set up. So I don't know that they'll ever change from that because it's designed to be a record review service. In terms of doctors all over the country comment on California patients, which objections have been raised. Objections have been raised where people have been seriously injured with medications being cut off. It would be difficult for the UR to implement telemedicine on the same cost basis. They probably pay the doctors per case and the amount of time allotted with which to review an RFA. To actually log on to a computer, get the patient organized. I don't know that that's a feasible plan.
Yeah, I mean, it's theoretical, but I was reading an article this morning. There's actually a lot of big forces moving around telemedicine. One publicly traded company, the name escapes me, but there's many. In fact, there was an interesting article talking about Australia providing daytime, they call it daytime, care per se, where the Australians during our nighttime hours, they're providing nursing care, monitored nursing care, and that being a huge morale issue. The morale issue being mitigated of working night shift with doctors and nurses. So I think it's interesting. I think it is developing, and I think we'll see more of it. I like it. I like that California has made this step. A little, this type of care, debating whether it's quality or not. I think that there's lots of things that can be done that is quality through telemedicine. But I see us making a big step, pushing the envelope here in this industry.
Agreed.
Yeah. So your overall thoughts of telemedicine, I mean, would you call it a net positive, net negative, or I just gave my opinion, but I'm curious what your opinion is.
I'd say it's certainly a net positive.
Okay.
I would say that there are visits every single day that if you're in the workers' comp system cannot be done in person for one reason or another. I have physicians that would only work by telemedicine during this time, and I don't know how long this time is going to last. No one does, not even Fauci. So given these facts that no one knows how long this is going to last, and the people that were susceptible, according to the science of the comorbidities, they're still susceptible in June. They're still susceptible in July. So I don't know how long. And without telemedicine, I think you would have a lot of doctors that couldn't practice at all. I think you have a lot of patients that could never get treatment. So it's definitely a net positive from a provider providing care to injured workers. There's no doubt about it.
Good. I think speed of the case is somewhat important too. I think it's really important. Obviously, our job is to get these folks back to work.
Correct.
So speed of case, I can see that being a factor. And even cost. I mean, I think that obviously Maximus, their cost would go up because they're adding services. But if you're trading a 1-for-1, a physical exam for a telemedicine exam, whatever that treatment or exam might be. It seems like it's going to be a little bit cheaper.
They did initially have a reduced fee schedule, as Kat was saying, for telemedicine visits. And then I'm not sure if it was the CDC or the AMA came out with it's the same fee. So I'm not sure which agency mandated that, but they brought the fee schedule back up to a telemedicine visits equal to a in-person visit. So, depending on the complexity of the visit, of course. But again, telemedicine has a place, and it should have a place going forward for a long time. How it's used exactly in the QME process, as was discussed earlier, I don't know that you could issue a final report without ever having a patient in front of you.
Yeah, good point. Yeah, and it goes back to our point, is physical examination is always superior. So on the personal side, lighten it up a little bit. So you're from the East Coast, right? Your accent doesn't give you away at all.
No, I'm from Sacramento. The east side of Sacramento. I'm from back east, New Jersey, New York.
Is that where you
Queens.
went? Yeah. Oh, okay. Any fun facts about Queens that us Californians can appreciate?
Not on the internet. Well, I grew up before Giuliani was the mayor, and New York, New Jersey, Queens was a different place. Giuliani did a lot of good things. I know that there's recent behaviors which people might not like or so forth, but back when he was the mayor of New York, his efficiencies of dealing with the duties of being a mayor, he worked tirelessly. And he cleaned up many aspects of New York City, where when I've returned over the recent decade, it's like a winter wonderland compared to what it was back in the 80s and 70s. So
New York took my breath away when I first saw it. Just huge, massive. I grew up in Bay Area, see San Francisco, and New York is 10 times bigger. It's amazing.
San Francisco is like a corner.
Yeah. So, Giants or Jets?
Jets.
Okay.
Unfortunately for me. Being born in Queens, that was where Shea Stadium was. Joe Namath.
Nice. Did you see the news? They announced NFL season is going to go on.
Well, they announced the schedule.
Yeah,
we'll see.
Are you a baseball fan?
Baseball fan.
Mets, Yankees?
Unfortunately, again, being born in Queens, I'm a Mets fan.
Oh, yeah.
They shared the stadium with the Jets. So, that's how that goes. And, wait till next year is a common phrase.
Wait till next year. Hey, I'm an A's fan, so I feel you.
A's they're competitive year after year, scrappy bunch.
That's right. You got to be underdogs. Well, I want to thank Rich Jacobs for coming on the podcast here.
Thank you, Dan Moore.
Wonderful time here just talking about some real issues. And I want to thank also Kat Angelis, who is General Manager NMCI. Thank you for your insight, Kat.
Kat's a champion.
Yeah, thank you guys. And we're happy to have you. You guys have a great day.
Thank you.